AHLA is pleased to present this special series highlighting the top 10 health law issues of 2023, where we bring together thought leaders from across the health law field to discuss the major trends and developments of the year. Support for AHLA in this series is provided by PYA, which helps clients find value in the complex challenges related to mergers and acquisitions, clinical integrations, regulatory compliance, business valuations, and fair market value assessments, and tax and assurance. For more information, visit pyapc.com.
Thank you for joining us for the third installment of the AHLA podcast series on the top 10 health law issues of 2023. I am Marty Ross with PYA. I am joined today by Jeremy Scherer of Hooper Lundy, who was the author of the article on telehealth, which certainly will be an interesting issue to follow through 2023. And Jeremy, if you'd like to introduce yourself to our listeners.
Yeah, sure. Thanks, Marty. I'm Jeremy Scherer. I'm a partner at Hooper Lundy. As Marty said, I'm based in our Boston office, work with clients in all 50 states, or our firm does. I probably can't count quite all 50 at any particular window in time. But I chair our digital health practice. So I primarily work with startups and scaling companies on all issues involving regulatory compliance and transactions involving digital health, and then also work with our health systems, SNF, practice groups, sort of brick and mortar clients on using digital health technology in a way that doesn't get anyone in trouble. So looking forward to talking telehealth today. I mean, there's a lot to sort of unpack as we head into 2023.
You know, I've been thinking, if I was sitting in this chair in January of 2019, and we had the issue of telehealth, it was kind of a giant yawn. We all knew the potential of telehealth. But the reimbursement mechanism was effectively non-existent.
Right.
And then a funny thing called COVID happened, and CMS changed the rules significantly, most importantly, allowing the delivery of telehealth to individuals in their homes, regardless of whether they resided in a rural or urban area. And it was that change in the rules, specifically good old 1834M of the Social Security Act, that allowed this to happen. All that being dependent on the public health emergency. And as you noted in the article, that was probably the big concern looking forward into 2023 is what would happen post-PHE. And then, as is always the case, Congress got involved and changed the rules. So can you summarize where we are today, at least in mid-January of 2023?
Yeah, certainly. And it's so interesting because I think we conventionally, we always say, as usual, Congress got involved. But for telehealth advocates, I think historically that's been the thing that we wanted to have happen, and that historically has not happened, right? These coverage and reimbursement standards were put into place in 1997, and since then there hadn't really been much change until the pandemic. But I guess as to where we are now, the way that I tend to think about this is, as with anything in healthcare, we're talking about a lot of complex, sort of conflicting, overlapping sources of authority and issues, really. So there are kind of three buckets in my mind. The first, which you alluded to, is Medicare coverage and reimbursement. Medicare is obviously the largest payer in the United States. Really, really important as far as sort of leading industry. And that has been historically an area where there has been very little utilization of telehealth, simply because it hasn't been covered or reimbursed for the most part. So there's what's going on with Medicare. Then there's, in terms of telehealth and pandemic, there's what's going on the state level in terms of state law and scope of practice, whether folks can provide care via telehealth in compliance with the law, and what exactly that means. And then the third bucket is the controlled substances prescribing issue, which of course is under the jurisdiction of the DEA, and is a totally separate issue. So sort of going through the three and kind of where we are right now. At the very end of 2022, heading into 23. The Consolidated Appropriations Act of 2023 was signed into law, which took that first bucket of issues, the modification or waiver of all five of the sort of core Medicare telehealth services coverage and reimbursement restrictions, which involve being in a rural HIPSA health professional shortage area or other certain other designated areas where there's a public health demonstration going on, being in an approved category of originating site facility. You mentioned, that the waiver of that requirement was what enabled folks to be able to get care in the home. Looking at the type of technology that folks are required to utilize in the Social Security Act, there's this definition of an interactive audiovisual communication, which means it's a fancy way of saying a synchronous audio video sort of video visit, like akin to what we're like having right now. Yeah. Exactly. Talking about the categories of practitioners who can bill for Medicare telehealth services, and then the list of services that can be covered when they're provided via telehealth to a Medicare beneficiary. All of those requirements were either waived or somehow modified during the pandemic, and it wasn't clear what was going to happen once the public health emergency ended. There was and in the Consolidated Appropriations Act of 2022, there was this 151-day off ramp that was not just proposed, but it was put in place as Congress effectively, in consultation with CMS and everyone else, wound up deciding that wasn't the path forward. And the majority of those Medicare-specific waivers have been extended through the end of calendar year 2024. And so what that means is we now have this window, and all along, I mean, even pre-pandemic, you were saying, 2019, we were those of us, who've been doing this a long time, we're talking in 2018, 2019, we were looking at Medicare Advantage potentially and the flexibilities that we had there and saying, we just need the data, because there continues to be this frustrating hesitation from MedPAC and others about whether telehealth actually increases quality. And then what's really come to the forefront more lately is whether it leads to increased utilization and increased fraud and abuse. And I think the idea in industry is that hopefully with the pandemic, the last couple of years, and now we have through the end of 2024 to really get a robust set of data together to really be able to show that telehealth is a way to deliver care. It's not something that's clinically distinct at all. And the minute that folks jump onto a video visit, they don't suddenly become fraudsters, right? Because they're still clinicians who are delivering care to their patients. So that's kind of where we are with regard to Medicare. In terms of the second bucket, where we are in terms of state law, during the pandemic, every state in the country made it easier to provide care via telehealth in some way. Some states went much farther than others, but in general, there were waivers of licensure requirements because folks were moving around much more, and the idea was we wanted folks to stay in the home rather than go out as a way to combat the spread of COVID-19. A lot of states have modified state law to keep up with the sort of trends and what's happening and what consumers are demanding, expecting. And look, I mean, telehealth is just a tool, but it's a really good one. And it's one that patients tend to like. And increasingly, it's one that clinicians like as well. The payer conversation is a little bit different, but so there's a lot that they need to unpack. But certain states during the pandemic, you look at Arizona, you look at Massachusetts, you look at Kentucky, you look at others. There are laws that are evolving and that are changing to try and sort of maintain, to an extent, what we saw, the landscape during the pandemic with regard to telehealth. Obviously, we don't want to maintain the landscape with regard to the spread of the coronavirus and a public health emergency or in a pandemic. But with regard to telehealth, there have been efforts to make sure that is going to stay in place. And then the third bucket is this controlled substances issue, where we unfortunately we really don't know what it's going to look like. So
the DEA at the beginning of the PHE exercised its statutory authority, correct? And said you can prescribe a controlled substance based on a telehealth visit as opposed to the traditional face-to-face, correct?
Yeah,
That
so the Ryan-Haight Act provisions of the Controlled Substances Act say that a valid prescription is one that is issued by a practitioner who's acting in the usual course of professional practice for a legitimate medical purpose, and it's prescribed by a clinician who has performed at least one in-person exam of the patient, unless there's a covering practitioner exception, and then there are these practice of telemedicine exceptions, and they were introduced back in 2008 and haven't really kept pace with much of the way that telehealth is provided these days. But when you go through the practice of telemedicine exceptions, one of them is that there's been a declared public health emergency. So it was pursuant to that authority that this in-person examination requirement, which is usually required at the federal level to prescribe controlled substances, was waived for the duration of the public health emergency, as well as the DEA also requires, in addition to being registered with the DEA to get a controlled substances prescribing, basically authorization or registration in the state where the practitioner is located, you also need to get that registration in any state where a patient to whom you're prescribing is located. And that requirement was waived in March 2020 for the duration of the pandemic as well.
But unlike the telehealth Medicare coverage rules, the door is going to come slamming down the day the PHE ends on controlled substances, right?
As far as we know at this point, yeah. I think there's the conventional. The conventional wisdom is that there's going to have to be some sort of transition, some sort of off ramp, just from a continuity of care perspective. When you're talking about controlled substances, you're talking about folks who are getting care that they really need, and the reason why these drugs are so heavily regulated is that they're really powerful, and just in the way that they can really help folks address really, really, difficult conditions, whether it be, substance use disorder or the ADHD is getting a lot of attention right now. These are also things where if you just pull the rug out from under people, you can have really adverse events and consequences in terms of withdrawal and that sort of thing. So from a clinical perspective, I'd have to imagine there will be some sort of off ramp, but the only indication that we've had from the DEA so far, and this is what they've been pointing back to when they've been asked about it, is this March 2022 statement where they made clear that they are committed to maintaining access to medication-assisted treatment that's delivered via telehealth post-pandemic. And so there's some, sort of reading tea leaves, there's some expectation that in the Ryan-Haight Act, there was this special telemedicine registration that was supposed to be created back in 2008. It was called for by Congress. It's been called on by several presidents, and it hasn't happened. We're now 14, 15 years later, and it hasn't happened. We understand that there is a proposed rule at the OMB, at the Office of Management and Budget. It's been there for a year, if not more at this point. But again, we don't know this. It's conjecture, but it looks like that registration may be specific to very important treatment, mind you, for substance use disorder involving medication-assisted treatment. But that doesn't cover all of the ways that the care has evolved during the pandemic, thanks to these flexibilities. So if that is what ends up happening, it leaves a lot of providers and a lot of patients in limbo, frankly.
Yeah. Let's go back to the state law regulation of telehealth. Can you explain? I've heard these terms bantered about, but I'm not quite sure what the legislation looks like. What's coverage parity? What's payment parity? What are these state laws attempting to accomplish?
Sure. So parity laws at their core intend to require payers really to treat services delivered via telehealth just like services that are provided in person. And coverage and payment parity laws address parity of different types. When you're talking about coverage parity, the principle is that when a service is covered when it is provided in person, let's say talk therapy. If talk therapy is covered when you're sitting in a psychiatrist or social worker or psychologist's office, and that clinician determines that they can provide that talk therapy service in a clinically competent manner through again, a synchronous audio video interaction typically, although there's some other types of technology in store and forward and things that we could talk about as well. But the idea generally is that if that talk therapy service is covered in person and it can be provided in a clinically competent way via telehealth, then it is also covered when it is provided via telehealth. So that's sort of step one. And most states have coverage parity laws in place at this point. Payment parity is sort of the thornier issue. And what payment parity stands for is the proposition that in addition to covering that talk therapy service when it's provided via telehealth, the payment parity laws require payers to pay the same amount for that service that's delivered via telehealth as they would if the service was delivered in person. And fewer states have payment parity laws on the books. And it's a contentious issue. And it's one, I mean, we're seeing more and more states have payment parity laws in place, in addition to coverage parity laws, as telehealth becomes sort of part of that clinical toolkit, as it were. But there are real debates that go on, even in states that are perceived as historically quite progressive with regard to health policy and coverage of things like telehealth benefits, where payers often want to be in a position where they're free to negotiate rates and not sort of bound by what state law.
And again, they're state laws, so these parity requirements don't reach ERISA regulated plans, correct? So again, that wonder of the regulation of health plans, we end up with two sets of rules: ERISA rules and state law rules.
Right. And that's about as far as I go. I'm not an ERISA lawyer, but insurance is regulated state by state, and then you've got the ERISA preemption issue, and it's complicated and something right. And we it's something that on a state by state basis we need to continue monitoring.
I apologize for jumping around. Let's go back to Medicare for a minute, because
sure.
At the same time that Congress provided that 151-day off ramp, they also, I think I may be confusing my laws, and I apologize, but they also created a permanent coverage for what they termed mental health services in the statute. So they eliminated the geographic and location restrictions for those services, but they imposed this requirement that prior to initiating services via telehealth, the practitioner had to see the individual in person within 6 months prior. Now, how does that square up with the now extension of telehealth through December of 2024? If I'm a practitioner, do I need to make sure before I start telehealth services that I've seen that patient within the last 6 months, face to face?
Not yet. So that rule will not take place until after at the very late. Well, it has been extended. That waiver's been extended through the end of calendar year 2024.
Okay. So
that's not something that you need to worry about yet.
Okay, so that's one of those looking past to 2025, and who knows what's going to happen. And exactly. I guess that's along those lines. As I understand it, the reason Congress has not eliminated the 1834M restrictions has been the Congressional Budget Office places such a high cost, a high price tag on these telehealth services, because they consider telehealth additive as opposed to substituting for a face-to-face visit. Any chance that CBO is going to change their mind? Is that going to be part of this research we hope we're seeing with the extension?
In short, yes. I mean, that is what we are hoping to see. And historically, I mean, the data hasn't really shown to date that these concerns around cost and fraud have really come to fruition. Everyone has anecdotally the Medicare beneficiary in their life who, you think about. I have a grandmother who's 94, and she's incredible with her iPad. I mean, she and my 3-year-old almost they FaceTime independently of my wife and I. And the thought is, well, now that, Jeremy's 94-year-old Bubby has her iPad there and she can just, press a button and see her doctor, she's going to want to see her doctor 4, 5, 6, 7 times a day. that's part of the concern. I don't think we've seen. I think that's sort of an anecdotal concern, although unfortunately, as you know, folks in the space know, that oftentimes does drive policy is sort of anecdotal experiences from key lawmakers and their staff. We haven't seen that happen yet. And in turn, the point that you made about whether telehealth is additive or can stand in place of those physician services that folks are receiving is a really important one. And I think what we've again, the data to date hasn't shown that folks are going to the doctor twice as much and deciding to do their in-person visits and then a separate bucket of telehealth visits in addition to those in-person visits. But that's part of what we need to see in the next couple of years.
In your article, you reference an OIG report that came out, last summer of 2022.
Yeah.
Kind of looking for fraud where fraud may be. Is that of concern? Should our compliance folks be worried about the potential of audits in the telehealth space? What's the potential issue there?
Yeah, I mean, so that particular alert focused on what that really was less, if we're talking about brick and mortar facilities and folks that are providing care via or greatly expanded the care that they were providing via telehealth during the pandemic, but who have those practitioner-patient relationships with these folks that are longstanding and involved in person care. The OIG special fraud alert was actually targeted more at historically direct-to-consumer telehealth platforms and practices that for a long time have been quite common in the cash pay space, where you're not subject to the federal fraud and abuse laws, like the federal anti-kickback statute. You're not Medicare rules also don't apply. But for a long time, a lot of telehealth companies said, we don't want to deal with this really complex reimbursement landscape. We certainly don't want to get anywhere near federal fraud and abuse laws. We want to stay outside of the HIPAA landscape if we can. And so we're just going to provide care direct to consumer. As the telehealth industry has grown, a lot of those really successful companies, some of them are now publicly traded, they've sort of scaled. And at a certain point, they realized that the Medicare market is really substantial and started wanting to provide services to Medicare beneficiaries. And so you've seen more and more of these telehealth first platforms that are providing care to Medicare beneficiaries. And in the process, some of these practices that have been common in the cash pay space, where you're not subject to all of those rules, have started to creep in to the Medicare landscape. And when a special fraud alert is issued, it's a noteworthy event. I mean, this was the first time in something like a decade that the special fraud alert had been issued. And basically what it says is, we, OIG, see that there are things going on in the industry that we don't like, and we want folks to stop them. That being said, I think that most of in that special fraud alert, most of the things that were highlighted are not likely to be the case with brick and mortar facilities and larger sort of medical practice groups and folks that are treating their patients via telehealth, because it's things like limiting a practitioner to only be able to utilize certain modalities to provide care. So you think about certain platforms that maybe only do remote patient monitoring or only do another specific type of care. And really what OIG was talking about there is, if you have a situation where a practitioner can't make a referral or see that there is a patient comes in thinking that they need an RPM service, and the practitioner says, wow, there's a cardiac issue here, I need to get you to a cardiologist. If they don't have the ability to make that referral, that's something that OIG, they didn't say that it was illegal, but they said that they view that as suspect. The advertising waiver of copays indefinitely, that was something that, again, OIG labeled as suspect. These things aren't illegal, but for the most part, when talking with clients about this, the challenge right now is really avoiding being perceived as a bad guy, as it were. because what I mean, in this special fraud alert, what OIG is going after is pretty problematic conduct. And so generally when you're working with companies who are engaging outside counsel and trying to go about things the right way, we're not really concerned that if OIG were ever to look under the hood, that they would, suddenly discover that this is a massive fraud scheme. But the problem is, in lifting up the hood and paying lawyers to stand next to the OIG as they look under the hood, that's an expensive and disruptive process. So we're trying to make sure that folks don't get caught up in that mistakenly. Where there is likely to be enforcement that's going to impact really everyone in the healthcare industry who is providing care via telehealth to any beneficiaries of public programs, whether it be Medicare, Medicaid, TRICARE, or otherwise, is audits. We've seen an unprecedented number of audits initiated by largely the OIG, but also state Medicaid fraud control units, the state Mafukus. They have an annual training, and I spoke on a panel there just talking about telehealth law, because it's an area that is so new to those investigators, and it's something that I think there's a bit of a blind spot concerning. And so they're getting up to speed, and they are, these are the way that one bills for telehealth services is different than other services, in that you need to have both the, at least, when you're talking about hub and spoke models, the originating and distant site claims that are submitted. And so it's those sort of nuts and bolts things, like making sure that you have both claims that line up to avoid any sort of appearance of impropriety that are really important. But I do think that a lot of provider facilities are going to be audited, not because they've done anything wrong, but simply because as we look at this data and try and figure out what telehealth is going to look like going forward, the conversation we had before about the CBO, they're going to want to know what's going on in terms of the spending, and make sure that that there isn't anything untoward going on.
Yeah, on the topic of billing for telehealth, the 2023 Medicare Physician Fee Schedule final rule set up the rules on what the post-pandemic world would look like, and CMS announcing that it would require the use of the appropriate place of service code to indicate telehealth, and most concerning, that they would discontinue paying at the facility rate. At the non-facility rate. I always get it backwards. At the non-facility rate. And then instead now, for telehealth services, even if provided an independent physician practice, the reimbursement would be at the lower facility rate. Of course, CMS made those rules up before the Consolidated Appropriation Act of 2023. Do you expect CMS to come out and say, we'll keep our rules the same that we created for purposes of the PHE? We're going to keep those rules the same through December of 24, or do you expect we're going to have sort of a patchwork of, well, this rule will apply, but that rule won't apply, coming out of CMS? And how do you think, have we heard anything from CMS on any of these topics yet?
I have to imagine, just thinking about it, looking at the sort of the arc of the pandemic and what CMS has done, I think that they've done an unusually good job here trying to look at the experience of industry and figuring. We had all of those town halls early in the pandemic where they were saying, wow, we didn't realize that folks were going to use audio only in the way that they were, and so on and so forth, and making corresponding changes to reimbursement policy. I'd have to imagine that they're going to try and reconcile what they're doing with the approach that's being implemented under Congress leadership. But that is really, at least I've not heard anything. That being said, Marty, you're probably more in the weeds than I am with regard to Medicare payment rules and specific policy in that regard. So to the extent you've heard anything, please say so.
No, I'm just the nerd that checks the website every day and nothing yet. So, Jeremy, I could talk telehealth with you all day. Fascinating topic.
We don't want to put anyone through that.
I know, we don't put anyone through that, but your insights are just great. The article really highlighted these key issues. And thank you for going in greater depth. So, everyone, thank you for joining us, and stay on the lookout for part 4 of the series.
Thanks so much, Marty.